All right. Well, good afternoon, good early evening, folks. Late evening or nighttime for folks in Europe. I was thinking about why would they give me this slot. It's probably because 5 o'clock on the East Coast of U.S. Middle makes sense for those in the West Coast, and this is probably a U.S. centric talk. So thanks you all for being with us today. I am Dr. Viet Nguyen. If you didn't attend the morning session and see my tattooed arm, I'm the Chief Standards Implementation Officer for HL7, as well as the Technical Director for the HL7 Vinci project. Our topic today will be the role of HL7 FHIR in patient cost transparency. And these slides are really taken from the work that we do in the HL7 Vinci project around patient cost transparency. So we'll tell you a little bit about Vinci, talk about the PCT use case, the regulatory framework that it sits around, as well as talk about the workflows and profiles and an example from the implementation guide. So in the audience, how many here actually write code in FHIR and are doing FHIR implementation? Okay. How many of you are, let's say, analyst, manager kind of level folks? Okay. And then everyone else just kind of does other things, clinicians and executives and such, okay? So I'll just warn you that it's not, I'm not going to go deep technical, although for some it may be, but we won't be digging into the any code. So.
Could you speak closer to the mic?
Oh, I'm sorry. Yeah, I always tend to do that. Okay, I apologize for that for the folks watching remotely. So just a brief overview. The Vinci project was formed just over 4 years ago. We're in our 5th year to really bring together the provider, vendor, payer community to identify good use cases and workflows to support value-based care. But in reality, we're also doing work around fee-for-service with prior auth and other use cases. But really, this patient cost transparency is a good example of where we need pricing transparency in order to do value-based care. But really, the idea, like the other accelerators, is to bring the community together in advance so that they can identify their needs and their use cases and then provide their subject matter expertise as well as their funding resources to bring contractors and subject matter experts to build FHIR IGs. These are a number of IGs. We have about 13 or 14 of them, ranging from clinical data exchange between payers, providers, and providers. Quality FHIR IGs that are being looked at by CMS and NCQA and others, and a number around burden reduction and prior authorization that I give a talk about on Thursday. A number that are actually in production now based on the patient access API final rule that came into effect in July of last year. So if anyone asks you, like, is there FHIR in the real world, you can certainly point to not only the EHR vendors and the work that's been done there, but also to the payer community in adopting patient access API. And then we have a number of other IGs that we call kind of foundational IGs around notifications using FHIR and member attribution, or just kind of patient lists in FHIR. But the one we're going to talk about today is this patient cost transparency. And that really, the goal here is to develop an exchange mechanism for using FHIR to support the exchange of cost and payment data between payers and providers, as well as to the patient. And one of our participants shared an article today that communities that have that are very competitive, that data is more readily available to the patients than it is in communities where there might be dominant providers, even though there are regulatory requirements for hospitals to make available in machine-readable format, not necessarily FHIR, their 500 top charges, services, shoppable services. Yes, thank you. So the idea here is that we want to be able to create a FHIR framework from which providers, when they are notified by a patient about a scheduled service, that they can submit to a payer what's called a good faith estimate based on what is expected to be delivered during the service. That good faith estimate would be received by the payer, processed by the payer as we're calling a pre-adjudicated claim, and the payer would provide back to the patient an advanced explanation of benefits. I'll ask here, who here knows what an explanation of benefits is? Well, that's good. Okay. Well, it turns out there really isn't a industry standard for what that looks like on an explanation of benefits. We have a general sense of what's in there, and so that's been a little challenging. Fortunately, there's work that we leveraged around the Caring Alliance and what they did with the Blue Button, which is a lot of EOB information from payers. So we leveraged that, and it turns out, based on our work, we have about 85% coverage of what they did, and most of what wasn't covered were things that they didn't feel like they had needed, that we did. So the idea here then is, well, let me back up. What's the problem we're trying to solve? The problem we're trying to solve is that today, as a patient, you go in, your provider, your physician tells you that, oh, you need let's say a diagnostic study. You're a good patient. You might double check, make sure where you go to get that study done is covered in your network. And if you're fortunate, everything's covered and you pay your deductible and you're good. What's happened though, and many of you may have had it happen to you, you go to a hospital for a procedure of some kind, and you may have called up to the hospital, make sure they're in your network, make sure the surgeon's in your network. You go, you do all the prior auth if necessary, you walk into the hospital to check in, and they give you a ream of paper. And you either essentially sign that ream of paper and get your procedure done, or you don't sign that ream of paper and you say, oh, I got to reschedule, or I just don't get the procedure done. But somewhere often in that ream of paper that says you accept responsibility for any charges that are not covered, paraphrasing, by your payer. And you trust that you did all your homework, everybody's in network, you have your procedure done, you get the bill at some point, you get an EOB from the payer, and then potentially weeks, months later, you get a bill from an anesthesiologist. Wait, isn't that the person I met for like 3 minutes before they injected something and I fell asleep? Oh yeah, turns out they weren't in your network. And so you have to pay an out-of-network charge. And as we know, hospital bills are one of the major, if not the #1 cause of bankruptcy and financial issues. So what happened was, lots of folks recognized that was an issue, and they went to Congress and put into I think an omnibus bill back in 2020, December 2020, the No Surprises Act. And the goal of that act was very laudatory, which was to make sure that patients didn't get these surprise bills. The challenge is, it was written by legislators who don't necessarily do technology and didn't quite realize how complicated it is, and also made enforcement guidelines that were really aggressive. But recognizing that we have a law, we're going to do our best to comply with that law. There are no standards to support this law. And so the Da Vinci project, being a collaboration between payers and providers, took on the effort, because we'd actually already started the conversation around cost transparency, to try to address this. And so we initiated initial discovery, grew out the discovery, went to HL7, says we need to do a project on this. We initiated the process with HL7, formed a group to work out the workflow that we could define, and then we developed an IG, balloted, and now we're in the midst of ballot reconciliation for those who are not HL7 regulars. And our hope is to have it published and reconciled and published by Q4 this year. But in reality, and I think the CMS folks will have said this in the past, is that there are several pillars that they are looking at when it comes to engaging the broader health IT community and the specific Medicare, Medicaid community in the US. One is around making the cost of care more transparent, making access to care better, and reducing the burden for clinicians in delivering good care to the provider. And underpinning all this is interoperability. So here we kind of note 3 major legislative things. Not all of them involve FHIR, but We have the Patient Access API, which essentially brought in the payer community doing FHIR, making FHIR resources available to their Medicare, Medicaid, CHIP patients, and many of them actually make it available for their commercial patients too, access to FHIR data, much like you can use with HealthKit with your EHR. And that's not only clinical data like US core data, but also the Care and Blue button and the explanation of benefits type data. So that's really good. So getting the data is essential. We also made the provider directories available, formulary, and started the conversation around the payer-to-payer data exchange, which they have put on hold because of there wasn't a requirement for non-payer covered folks to share with FHIR, and so they're holding off. But so the next was this transparency and coverage, which is the hospital shoppable services. But that's also not in FHIR. We held off on that one in our project because the requirement to comply was already was already initiated before we had time to really spin up anything. But then we expect that there are going to be some others that are on its way. Last year we had the prior authorization, burden reduction prior authorization proposed rule that became a final rule and then got held up by the new administration. And we expect that they're going to release an NPRM this year for prior authorization as well. But all these are really an indication to you all that CMS and ONC is really going full bore on interoperability and the use of FHIR for a number of use cases and workflows, and they're likely, in my opinion, to do more. But really, in order to do this cost transparency, we have this No Surprises Act, so we have the good faith estimate, advanced DOBs. We had some of the components going into effect in January this year, and then some were kind of held. But really, folks are looking at January 2023, but we're still waiting for the rules around that. And I mentioned the hospital one and the transparency and coverage rule as well. But the idea is that we can't really have an informed patient if, one, they don't have access to their clinical data, and two, have access to cost and price and charges, because otherwise it's not really a true market. So this is a long statement. You don't have to read, but really we made a commitment as part of Vinci to pursue this because we felt like we were the right community of stakeholders. We had good representation of some large provider systems as well as the payers to try to tackle this. But what we realized is that we couldn't tackle it all. And so we started on the first part, the part that getting to the advanced EOB. So if you look at this workflow, we have a number of work streams. So on the left is this the patient who initiates, along with their provider, some service that needs to be scheduled. How that gets triggered in I'm going to say a technical workflow is still not clear, because if any of you have tried to schedule something, a procedure with a payer a provider at a hospital or a radiology center, it's not always the same. You're not always going to talk to the same person. So the idea here is that you have a convening provider, and there's still a little bit of debate about how you define a convening provider. One definition that I think I've gotten a number of providers to agree on is that in order to deliver a service, you need a patient, you need some clinician, probably, you need a location to deliver the service. And we think that whoever is responsible for that location and billing of that service for that location would probably be a good, stable definition of a convening provider, because that's whether it's a radiology center, a hospital, outpatient surgical center. Somebody has to have a space for you to deliver a service. But then, so that convening provider today may be a single comprehensive entity like an academic medical center where they know all the participants in the care, or in reality, actually a convening provider that brings in both their employed physicians as well as community physicians that practice, say, in a hospital. So one of the challenges we have is that that convening provider for today we think is expected to submit that bundle of the good faith estimate on behalf of all the participating providers. And so one of the challenges we have is, how do they know who else is participating? And that answer is not always clear yet, because today that might be some scheduler or some central process. They say, oh, this is a surgery. I need the surgeon who's doing the surgery. I need an anesthesiologist. I may need radiology services. I need the patient. And that all kind of comes together over the course of time to decide which anesthesiologist is on service that day or which group is on that day. So the reason I want to bring this up is that this implementation guide doesn't address that. And it doesn't address that because, honestly, I said to the provider community, we don't think we should be creating a workflow and an exchange where you all haven't agreed on what the workflow would be. So their response, the American Hospital Association, the AMA, MGMA, and a number of large provider systems decided they would bring a group together and start sorting this out and figuring out what are they doing today that might be a good opportunity to come to a unified workflow in order for the standards community to then develop a technical approach to that workflow. So that's something important for you to think about as if you're going to be working in trying to help develop specifications, is that it's way easier to develop specifications when there are at least some agreed upon workflow, some data that's being exchanged, and if the data is not standard, that's the great opportunity. But we expect in step 2 here is that we have a bundle, a collection of good faith estimates from that convening provider submitted to the payer. That payer then processes this bundle based on the beneficiary's rules, the members' rules, and their deductibles and all those things, and then makes available the advanced explanation of benefits for the patient. The legislation didn't define what it means to make it available. There's certainly opinions, but for now, we're leaving a certain level of ambiguity there, because you could have a payer portal, you could have it a letter, on paper, or what I would personally think would be great is if we made it available in the same way the FHIR Patient Access API portal, the patient portal, would make it available. That way, we're leveraging existing payer technologies. Another aspect in our implementation guide that is not a requirement, but something we heard from the providers, is that the providers want to know what's being sent to the patient. And you might ask, why would that be? Mainly because the providers are on the hook. The payer is using information the providers send them. They're processing it with their rules and their beneficiary coverage. They're saying to the patient, based on the information we have, this is what your advanced explanation of benefits is going to be. And that's only as good as what the provider sent to us. So the providers are saying, okay, we want to know what that AOB is because we're on the hook, and we want to be able to have a conversation with the patient, which is actually a good thing, right? Because if it turns out it's really expensive, it may be something that's worthwhile. Some of the challenges, if you're in a single monolithic hospital system with all employed providers, that's not so bad. But there is some concern about providers who may be competing with each other, knowing what their rates are. And so it's another place where Da Vinci says, we made the first pass, this AOB, comprehensive AOB, the same one that's provided to the patient, can be made available to the provider via FHIR, but we haven't broken it down so that each provider only sees what they contributed to the GFE, because that problem is upstream from where the providers had to submit the GFE. So this is kind of complex, despite the fact that it seems a little more straightforward earlier on. So just to review, though, what goes into this good faith estimate? The good faith estimate is essentially what does the provider expect to charge for this scheduled service? So part of that, we have a profile on the patient, the coverage, an organization, the payer organization. We would have to break down the relationship of each of the providers to whether or not they are an institution or an individual practitioner. Then we have to be able to list estimated date of services, diagnoses and procedures, and anything else we think that needs to go in that would go in reality after the service was delivered. And so something that comes up frequently in this conversation is, well, what if something happens and I go in to do a exploratory abdominal laparoscopic surgery and it turns out there's a tumor and now it's a whole lot more complicated? My response is it's a good faith estimate. And in terms of doing a good faith estimate, you use the information that you know at the time you make the estimate. And there will probably be a number of disclosures and caveats that go to the patient regarding this good faith estimate. And I try to help the providers, especially the doctors, not get kind of wrapped around the axle about the complexity of healthcare, because healthcare is complex. Go with what you have available when you have it and do the best you can to express that. But what we really think, though, is the providers will really have to metaphorically sharpen their pencils. They have, I'm sure, a history, the data on a range of patients and a range of complexity for these kind of services. The question is whether or not it's information that's accessible, that's been analyzed, and that they can use that information or update it for the patient in front of them. So what does it mean to do a total knee replacement on an otherwise healthy 55-year-old versus a 55-year-old who has diabetes and hypertension? I think we have the data. It's just probably not been analyzed to the extent that we could. So I think that's a big opportunity. And really another big opportunity is figuring out how do you coordinate your other providers? How do you know who's working in your system and organizing them and being able to share? Because some thought was, well, maybe you just get a list of all your providers' charges. That might be okay, but the reality is that might not be what the charges they send to their particular one or more payers, right? So there's complexity there. But assuming that we can gather this bundle of providers and the charges, and we create the equivalent of an X12 278, I believe, and one of their newer versions that allows us to do this pre-adjudication, the payers would utilize or reconfigure, I would say, so that they can do this a predetermination claim. They already do something similar around the kind of a zero charge claim, but something like that allows them to process this and use all this beneficiary and patient coverage deductible premiums kind of information, and then send this, create this AEOB. So with the AEOB, we would expect that they would be able to then have each line item to say that this was the service that was billed, this is the service, this is how much we cover, and this is the patient's, that goes to the patient's deductible. One of the interesting terminology challenges is that providers can submit CPT codes, HCPCS codes and other codes, and those have standard titles. But if you're a clinician, you know that a CPT code for a certain diagnostic study is not actually the diagnostic study you do. So there's a good discussion around where do we combine the standard terminology of the codes and then try to make these codes more readable and patient-friendly. And we have the payers may use the same code, but they use different descriptions of those codes. So what I asked them kind of land on is the code is what's being processed. The representation of the code is what the organization wants to provide, and FHIR supports both in that human readable form. The code matters more in FHIR than the text does. So don't read this either, but this is an example that I shared earlier about, and what we've been trying to do is try to start with useful common examples and add complexity on top of them, as opposed to start with really complex examples. And so this is just an example we use of a head MRI that's being scheduled or ordered by a provider. Patient has to call the radiology center, get it scheduled. That radiology center has to submit the GFE to the payer. The payer then processes it gets it back to the patient, and then the patient can have it, and an optional step to make it available to the provider, because that is optional. It's not a requirement as part of the law. So what we are hoping in our conversations with the payers and providers is that they both come to some agreement about the importance of it, so that we can relay that to the broader community and CMS too, if they want to consider that in some of their policies. So I will share the slides right after. I was updating some of them. So there's a link to the Da Vinci, the patient cost transparency IG. But in general, if you need to find anything on Da Vinci or any of our use cases, any of our work, go to confluence.hl7.org. And on that front page is a link to Da Vinci. And on the left-hand side in the navigation menu is our implementation guide dashboard that lists every IG we're working on, a link to the IG, a link to the reference implementation, the code, the GitHub code, as well as the, I think even JIRA if we're in ballot reconciliation, and the reference implementation, yeah. So we have now tested these at a couple of different connectathons, because we've been working pretty fast on this. And we did a demonstration at HIMSS. We did a demonstration in May at our connectathon. One of our Da Vinci members, Edifex, actually was able to take the reference implementation as input, process it through their actual engine, and spit out an AEOB on the back end. And so we have a couple of good demonstrations of this, but what we really need in order to get into any kind of reg is some more demonstrations. So we have a connectathon coming up in July with CMS. So if you go to the HL7 webpage, you'll find a link to our events, and the CMS connectathon will include this as one of the tracks. So if you want to see additional testing and demonstrations, you'll be able to see it there, along with a number of other Da Vinci and Karen and Gravity and maybe a couple of other tracks as well. So important. We are, as I mentioned, in the midst of ballot reconciliation, trying to address some of the description, some of the code system work. This is a good example, I don't know if I clearly mentioned this, of working together with X12 and HL7 and FHIR to show how we are able, we're using FHIR to support X12 content as it's being sent from one actor to another actor, as opposed to using the EDI messaging approach. I think it's a great way to show the collaboration, and it's a recognition that there is a huge implementation base around X12. And like many other groups, we're trying to sort out the must support. So that's a longer conversation that we don't necessarily want to have here. And then we're trying to figure out, there are a lot of business rules that are inherent in X12 and doing X12 transactions, some of which may rise to the level of must support, but we're trying to make sure we find that balance, because those business rules may change, whereas the must support things are really at a higher level. It's a little hard for me to explain, but we don't want to put too many of those business rules in the FHIR transaction unless we're confident that you always need a patient, you always need a provider, or those kind of level of rules. So there'll be a link to the GitHub, as well as an implementation of the payer side server and response. And we have a number of places where you can engage in the discussion of patient cost transparency. We have a 2-hour call every Friday at 11 o'clock Eastern, where we're working through the ballot reconciliation, and then we'll be doing the Connectathon in May and additional events as well. And we're being overseen by the financial management and co-sponsored by the PI, Payer Provider Interoperability Group. So this is the main contact for our Da Vinci PMO, and there'll be a bunch of references after around a bunch of acronyms I may have thrown out that I didn't explain, and other reference implementation. So I don't know how I'm doing on time. Oh, not bad, half an hour.
Yep, so we have 15 minutes, and I do have 5 questions virtually, 5, most about the advanced EOB, but I do want to open it up to questions as well here in person, so please raise your hand if you have a question. Okay, As I walk back there, I'll ask what hopefully is an easy one from the virtual folks. What insurance companies are piloting the advanced EOB?
Right now, we don't have I can't name a specific one yet, but the Blue Cross Blue Shield Association, on behalf of their members, are pretty actively involved in the development and of the guide and working through the guide. So at the moment, without their permission, I can't name any specific payer groups.
So I'm not trying to put you on the spot, Viet, but can you talk a little bit more about what kind of analytics you think this will enable?
So what kind of, I think the question, analytics on the provider end or analytics from the AUB end? So from the provider end, I think there's opportunities to do analytics on the provider end to better understand how they bill and organize their charges around services. And I know there's been a group who worked with CMS to look at charges based on Medicare patients, and showed how it varies so much from region to region, just based on practice in each region. But I think it'll be a way for hospitals, they need to be able to see how they do charges, and it may ultimately help them understand how to be more efficient in delivering the care. So I think it's just more data that can go to providing more efficient care, because it'll make them more competitive. Because if patients start having more and more data, and it turns out, let's say the university hospital provides the service and it costs X, and a commercial hospital in the same area that has the same payer costs X, 80% of X, that informs the patient on how they might respond. And then we add that to, say, quality data to show outcomes for certain, I knew you were going there. So, these procedures, that just empowers the patient more in terms of making their decisions and working with their own providers to make decisions. And on the other end, I'm not sure if this information is ever going to get to a third party who might want to aggregate and analyze it. Maybe. But I've heard people wanting to do that. Other questions?
Okay, another virtual question is Da Vinci going to require or just support payer to provider for advanced EOB, even though it's not part of the regulations?
So we are going to support it. So right now we support it because we in our guide define that the AOB, the one that is given to the patient, would be optionally made available to the provider via FHIR endpoint, because it's a fine balance between what is in policy, what we think might be in policy, and trying not to essentially create policy. So we leave it optional, and the policy makers say that it's required, they trump the guide. So that gave us some flexibility. And then when we get to the more specifics around separating out specific provider information, that's going to be really a conversation between payers and providers, because if the payers don't have to do it, they don't have to do it. So it has to make sense for them and seeing the perspective from the provider side. That's why we are trying to support that conversation.
Okay, I do have another one, but anybody here you go.
Just a quick question.
Sure.
Clarification on those target dates that you had up there.
Which one?
The target dates for the.
Let me bring it up. The publishing?
Yeah, is that the published dates then?
Yeah.
And how does that tie in with any CMS mandates?
It doesn't, because we don't have any. Our guides aren't required by any mandates.
Right.
So our philosophy has been to try to work as collaboratively and quickly as we can, and the regulators should ignore us, because you can't know what we're doing, and we can't tell you what we're doing.
Okay. So there's really not an enforcement target dates on those yet, and
No.
no expectation at this
No.
point what they'll
And I
look like.
definitely don't know of any dates.
Okay.
So I'm not even having any conversations.
All right, thank you.
They just want us to work with the community and build what we think is the best possible thing as quickly as we can.
Okay, here's another one virtually. Have the providers you've heard request advanced EOBs thought about their being on the hook for sharing them once the info blocking rules expand to EHI?
That's a good question. I honestly, that question has never come up in the conversation. And I think I would have to go back and look at the EHI and see if the AEOB would be part of EHI. So I don't know. So sorry. I'm happy to bring it back to our community and see if anybody's asked.
Okay. I have two more virtual ones. So again, raise your hand here if you have anything. Still on the advanced EOB. Okay. The question was, I may have missed it, but I didn't see anything being sent to the payer representing the patient's choice of advanced EOB delivery mechanism. The regs say the patient gets to specify the delivery mechanism of the AEOB, and the payer has to comply, which means collecting that choice at the provider and passing it to the payer.
Yes. So we don't specify that beyond recognizing that flexibility that the patient wants. Because we don't define how you do it via email. We don't define how you do it via paper. So we defined the option for doing it via FHIR. So assuming that that is one of the options given to the patient and a payer were to adopt this, that's how they would do it. We really were trying to leverage that, again, that patient access API as the approach that payers today have for getting information back to a patient via FHIR.
Okay, and the last one virtually was, do you think cost transparency efforts will help facilitate UDI, unique device ID, in the EHR or claims data?
I don't know, but my gut is telling me probably not, because UDIs, I think, are at the device, like specific device level, and I'm not sure, because I don't do the claims and how much that fits into claims. I mean, yeah, I don't know the link. Yeah, I mean, I guess if you had a specific device, you could have a device model, but I'm not a UDI expert, so I apologize. So I don't know.
Okay, I do have one more, a couple of new ones on the, uh-oh.
And I thought this was
Got
going to
them
be
rolling
easy.
now virtually.
Well, we're glad. We want you to be engaged.
All right, let's see here. So,
While you're asking that, let me ask the group, who here are provider or payer organizations that you think are going to be responsible to implement some aspect of this? Derwin, for sure. Okay, are you with payers or providers? Payers.
Karen expanded on her other question. Here goes, but the information that the patient gives to the provider needs to get sent to the payer. It has nothing to do with specifying the actual specifics of an email, but passing data the provider has to the payer who needs it.
That's the good faith estimate, is what the provider is sending to the payer in order to create the advanced explanation of benefits.
Okay. And then Mark Scrimshire added, this is an estimate, so there wouldn't be a device at the point you get an estimate.
Okay, thank you,
Yeah.
Mark. Why aren't you in
That's
the room?
okay.
I can't cover everything.
Mark out, but I figured,
Thanks, Mark.
I figured you'd appreciate that. So that completes all the virtual Q&A. Anybody here have questions? All right, we have 5 minutes left. That was the timer going.
All
off,
right.
so.
Well, thank you all for being here. I know it's late in the day. I hope you're having a really great Dev Days and learning a lot and connecting. Can I get a raise of hand? How many are glad you're here in person? Yeah, it might be buyer's remorse too, but I'm glad to see that. And how many would continue to come in person if it's available? Okay, that's great. Okay, we're at that place where having to make those decisions. How many would come to the September work meeting or connect-a-thon? Okay. Yeah, in person. Okay, good, half of you. Okay, great. Thank you so much. Thanks for being here, and enjoy the rest of the Dev Days.